So now I'd like to introduce our speakers. Dr. Murali Chakanala is a pulmonologist and co-director of the Washington University HHT Center of Excellence in St. Louis, Missouri. And Dr. Vivek Iyer is a pulmonologist and director of the HHT Center of Excellence at the Mayo Clinic in Rochester, Minnesota. Dr. Chakanala and Dr. Iyer were lead members in the GI bleeding management group, which recommended the now accepted standards of care for this topic area, making them the perfect speakers for tonight's conversation. And a special member of our panel today is Ividine Herder. Ividine is an HHT patient who has suffered from GI bleeding throughout her life. She's joined us today to share her experience and the importance of staying on top of your GI bleeding care. At the end of the presentation, all three panelists will be available to answer your questions. So now, while Dr. Chakanala turns on his video and shares his slides, we are going to launch a poll and ask you two simple questions. Anemia is the most common presentation of GI bleeding in HHT. Is this true or false? And for patients with severe GI bleeding, the best therapy is repeated GI endoscopy based on cauterization procedures. True or false? If you can please answer your question. So Dr. Chakanala, here are the results.
Hi, thanks, Nicole. Welcome to everybody. It's a real pleasure and an honor to be speaking to all of you about this topic of GI bleeding. I'm especially thrilled to hear that we might have a worldwide audience, which is a first for me. So I'm very excited to be a part of this. And I'll try to be the table setter for the discussion and serve up the conversation for Dr. Iyer as he goes through the guidelines. So before I give my overview, just to recap these questions that Nicole went over with us. The first one was whether anemia is the most common presentation of GI bleeding in HHT. And the answer is that, or the answer to the question is true, which most of you got, and we'll talk about that. And then for patients with severe GI bleeding, the best therapy is repeated GI endoscopy based on cauterization procedures. And this is interesting because it kind of split almost down the middle, but the answer is probably false. I'm sure Vivek will go over that as that's covered in the guidelines. So I'm going to close this out and start talking about the overview of GI bleeding. So just to set the framework for the rest of the conversation, I think most people in this audience either has HHT or is a family member that has HHT or takes care of patients with HHT. And hopefully everybody knows what the criteria for diagnosing HHT is. And more than 10 years ago, this was established through one of the HHT Foundation sponsored conferences in Curacao, and we call it the Curacao Criteria. And to make a diagnosis of HHT, a patient needs to have at least 3 out of these 4 criteria. And I start with this because one of those 4 criteria is the presence of internal arteriovenous malformations or telangiectasias. And a prime example of that are the gastrointestinal telangiectasias, or for short, we call it GI telangiectasias. So that is one of the cardinal features of HHT. And if you have that along with a couple of these other criteria, then you meet the definition of HHT even without necessarily having genetic testing performed. So what do GI telangiectasias look like? Well, in this slide, you can see this is a picture from an endoscope in a patient, and the normal background is this kind of light brown area, and this is what the normal mucosa, the lining of the GI tract or the gut looks like. And then we see these little red islands in between that, or in the midst of this normal area. And these are abnormal blood vessels. These are the dilated capillaries and small arteries and veins that make up a telangiectasia. You can see in another more distal or area further down in the GI tract, similar appearance, these red spots. Now, these folds are just the normal contours of the GI tract, but all these red spots are the telangiectasias, and I think you can understand why they might bleed periodically. Here's a close-up of one larger telangiectasia, and this is the probe that the endoscopist is using to buzz that in just a few seconds to get it to go away. And once they do that, it leaves a little scar like this, but that should stop any bleeding that might take place. But I just wanted you to see what one of these telangiectasias look like. Now, to orient everybody and remind us back to high school biology, as you can see in this cartoon, when we eat something in our mouth, it goes down by the esophagus into the stomach, which sits high in the abdomen. And then from the stomach, food and material goes down into the small intestine, which is the central part. And then once it makes its way through this, it winds up in the large intestine or colon. So the pathway is from esophagus to stomach to small intestine to the large intestine. And the reason I point this out is that when we say GI telangiectasias, they really can affect pretty much all of these structures, the stomach, the small intestine, or the large intestine. And what we've learned over the years is that the majority of the time, the telangiectasias tend to be in the stomach and the first part of the small intestine, and they become less common in the later portions of the small intestine, and especially less common in the colon. So let's talk a little bit of what we call epidemiology about telangiectasias of the GI tract. They're actually very common. And in about 80% of adults who undergo endoscopy, we will see some of these telangiectasias. So a very high percentage, and it is somewhat dependent on how old you are. But only about 30% of patients, we believe, actually have bleeding issues with these telangiectasias. So in many of them, it just becomes a marker of the condition, but may not actually be causing any clinical problems. So even though a lot of patients have it and a minority only have bleeding, it's not really recommended that we go screening for GI telangiectasias, unlike, say, lung AVMs and brain AVMs, where we do screen, because even if we found those types of lesions in someone who wasn't having problems, we may still want to treat them to avoid complications. Well, it's different in the GI tract for a variety of reasons, but suffice it to say, because it causes problems in such a minority of patients, we don't go routinely looking for them unless there's a question to be answered. It is very rare for people to present with bleeding, meaning having clinical consequences of GI bleeding before the 5th decade of life. So children, teenagers, young adults may have some of these telangiectasias, and again, probably not many, and they just don't cause problems at that young age. But as people age, we think the number of them, potentially the size of them, and the likelihood for bleeding seems to get worse with time. And as I alluded to a minute ago, they tend to be most concentrated in the stomach or the upper GI tract, and the small intestine next, and then finally the large intestine. And in fact, it's pretty rare to see them in the large intestine and not see them in the stomach and small intestine in an individual. And this is a key point I want to leave home. I know these things look pretty striking on the pictures, but the degree or the number that we see during endoscopy doesn't really correlate with how severe someone's anemia might be. And this is probably because there are other factors than just the presence of the telangiectasias that lead to bleeding and the complications of bleeding. So I hope that point makes sense, and we'll probably mention that again later in the presentation. And one of the criteria, or I'm sorry, one of the guideline recommendations emphasizes this point, that just the visualization and the number of telangiectasias doesn't necessarily correlate with the severity and what we should do therapeutically. So how does GI bleeding manifest in our patients? And this was one of the questions that we went through. So again, many people are unaware that they have them, and that even some of them may be slowly oozing and bleeding, and that's because they get enough iron in their diet that they just make up for the bleeding and keep up their red blood cell counts. The biggest or the most common way patients present is by developing iron deficiency with or without anemia. First, you get iron deficient, and then if it's bad enough, you become anemic. And this is because, unlike other causes of GI bleeding, where you may bleed a lot and you may throw up the blood or pass the blood in your stool and it shows up, in HHT, most patients will bleed slowly a little bit every day, and that blood gets broken down and mixed up with stool, and you really can't tell that you're bleeding. So I want to emphasize to patients that just because you don't see the blood doesn't mean you couldn't be bleeding. And unfortunately, this can go on for months and years, and then people develop iron deficiency because they've outstripped their body's iron supply, and now they develop symptoms of iron deficiency, which I'll go over in a minute. And then if it gets bad enough, they actually become anemic. Now, sometimes if someone bleeds a lot, you may see black stool, or what we call melena. This is pretty rare just from GI bleeding. It certainly can happen, but it's generally pretty rare because, again, it's a slow chronic ooze or blood loss that gets mixed in with normal stool. Now, assessing for GI bleeding on the patient's behalf and even healthcare professionals' standpoint can be complicated and confounded because our patients also have nosebleeds. Well, you say, well, what does that have to do with bleeding in the GI tract? Well, the issue is that sometimes people swallow the blood even though it's coming from up high in their nose. And whether you bleed in the stomach or you bleed in the nose and the blood makes its way down, as the blood decomposes in the GI tract, it'll look the same in the stool. So patients often say, oh yeah, I've had a lot of nosebleeds, and then the following days, my stool turned really dark and black. So that doesn't mean necessarily it's GI bleeding. It could be nosebleeds. Many of you are taking iron pills because your doctor recommended it, and that's good. But iron stains the stool to be dark too. Now, generally, you really can tell when it's the melena versus just iron. Iron tends to be darker, but the melena looks pitch black, and the consistency of the stool changes as well too. And then there could be other causes of GI bleeding besides the telangiectasias. For instance, you could have a cancer. You could have an ulcer, very common things that HHT patients aren't immune from having. So just because you might see blood in the stool or you might have dark stools, it doesn't necessarily mean it's telangiectasias. And in fact, one of the reasons why we would scope an HHT patient is if we're suspicious there is something else going on. For instance, if you're having blood loss and you're also having a lot of pain in your stomach, that's a tip off something else because telangiectasias generally don't cause pain. So we touched on this already, but the number one way that patients present with GI bleeding is that they develop iron deficiency and potentially iron deficiency anemia. Well, how does that impact patients and how do they present? Well, the main complaints that patients report is that they're just fatigued. They're just tired because they're low in blood count and they're not delivering enough oxygen to their organs, to their brain, to their muscles. And you can develop shortness of breath, meaning you're finding it's taking more effort from a breathing standpoint to do the things that you want to do. And when it gets really advanced, you can also see rapid heartbeat because the heart tries to make up for the low blood counts by pumping faster. And then there are a whole host of other subtle but important clues that someone may be iron deficient. There's something called restless legs. It bothers people where they just can't sit still or lay still without getting comfortable and their legs have to constantly move. This is especially problematic at night when people are trying to settle in to go to sleep. And you would be surprised that you have this complaint, you didn't associate it, and then someone finds that you're low in iron and gives you a whole bunch of iron, and you get a wonderful fringe benefit that your restless legs goes away. People can develop these unusual cravings, and this is not typos on your screen. Truly, people get cravings for these things. The most common thing is just chewing ice. Now, please don't take it, I mean, a lot of people like to chew ice. Just because you chew ice doesn't mean you're iron deficient. But if you're an HHT patient and you all of a sudden start craving ice and you didn't before, you should definitely get your iron level checked. And then some people actually favor eating things, inedible things like clay and even dirt in children, which could be a sign of iron deficiency. Chronic headaches is also something that HHT patients or people with iron deficiency can develop. And then there are more subtle things, cognitive deficits, poor concentration, poor memory, especially when this is a chronic problem. And then some things that doctors and healthcare professionals notice, and patients can too, is that their fingernails get very brittle and crack very easily. Then there's something called spooning of the nails. And here's a picture where it looks like there's a divot in the fingernail. This is also a sign of iron deficiency. And then some patients can have changes in their tongue where it becomes very smooth. You lose that roughened appearance, the papillae, and it can actually hurt. We call this glossitis, and this could be a clue for iron deficiency. And then patients also can develop cracking at the corner of their mouth, something called cheilitis. So if you see any of these things, then be worried about iron deficiency, and it's so easy to diagnose if you can just get a blood level check. So anemia is common in HHT. About 50% of patients have anemia, and it can be quite severe in up to 25% of patients. And again, part of the reason is because this subtle chronic GI bleeding. And severe anemia has considerable effects on people's quality of life, and it can even lead to cardiovascular or heart-related morbidity and even mortality. One extreme example is that patients can develop a form of heart failure. You'll recall that I said you can develop a fast heart rate. Well, if that fast heart rate goes on chronically for many, many months, you can actually develop heart failure. You feel like you're running a race even when you're just walking from one end of the room in your house to the other end. And it's important to note that bleeding, like nosebleeds and GI bleeding, complications related to that, including causing anemia, are some of the most common causes for hospitalization in HHT patients. Lastly, I wanted to just single out a rare form of HHT, and that's the patients who have a SMAD4 mutation. You've probably heard the other more common genes like endoglin and ALK1. And while those make up the bulk of HHT cases in our country, about 3% of HHT patients have a SMAD4 mutation. And in SMAD4, you can develop HHT, but you can also have an overlapping condition called juvenile polyposis syndrome. And that's what this picture is showing you. This is the inside of a colon of a patient, and they have this polyp right here. Well, these kind of polyps can develop in anyone, I should say, as they get older. And this is the basis for why once you turn 50, it's recommended that everybody in the general population have a screening colonoscopy, is to look for polyps like this. But if you're an HHT patient with a SMAD4 mutation, these polyps can develop much earlier in life, and they can be many at a time. And there's a risk for these polyps to becoming cancerous, especially in the colon or the GI tract. So the recommendation is that for an HHT patient with a SMAD4 mutation, you should start undergoing a screening colonoscopy from the age of 15, and then every 3 years get another one if no polyps are found. But if you find a polyp, even at the age of 15, then the recommendation is to do an annual colonoscopy and an upper endoscopy to look in the stomach too, because at such a young age of having lots of polyps, you're at an increased risk of developing cancer. So that's my initial general overview, and I'm going to turn it over here to Vivek in just a minute. And I just want to highlight again what Nicole touched on. The guidelines committee and task force was really an amazing experience, and these were the 60 people around the world, including physicians, allied health professionals, patients, and advocates. And it was a wonderful 3-day event in Toronto where we sat down and hammered out these guidelines. And I had the pleasure, as did Vivek, of being on the GI bleeding working group and hear the rest of the members. And it was our work that helped lead to these 6 recommendations that Vivek is going to go over. So with that, I'm going to stop sharing my slides and turn off my monitor so that Vivek can take over, but I think we have another polling question first.
Yes, thank you so much. So our next poll, while we set up for Dr. Iyer, you will see says, which decade of life does GI bleeding become more prominent? And the second question of the poll is, anemia and GI bleeding tend to be very common causes for hospital admission amongst HHT patients, true or false? So Dr. Iyer, you can see these results. If you'd like to explain on them a little bit.
Yeah, absolutely. I think everyone's got it right. I think, and I'm going to show you some data on that. So GI bleeding does increase in prevalence with age, so that's for sure. And yes, anemia and GI bleeding tend to be very common causes of hospitalization, and I'm going to share some data on that too. So everyone's got it right, most of you. All right, so I'm going to get started. Thank you, everyone, for joining. Thank you, Murali, for that excellent introduction. So what I will do is I'll spend the rest of maybe the better part of 20 minutes kind of quickly walking you folks through the guidelines. I'm going to try to leave as much of the original wording of the guidelines exactly as it is in the paper, just so that I don't editorialize anything and you can exactly see what's in the guidelines, and we can talk more about that. So I don't have any conflicts of interest as part of this talk or any other topic related to HHT. I really want to thank, as Dr. Chakinala said, I really want to echo his thoughts about thanking Cure HHT and the Christopher McMahon family. And I don't think this guideline symposium and everything that has come out of this would have happened without their support. So let's talk about these guidelines. So in the 2020 guidelines, we, from the GI bleed standpoint, came up with a total of 6 guidelines. We'll walk through those. And then the other topics in the guidelines are epistaxis and anemia. And that has been covered in a previous webinar. We are going to do GI bleeding, and there is liver vascular malformations, anemia, pediatric care, pregnancy, and delivery. So those are the other topics that were covered. And some of the topics from the 2009 guidelines were not revisited, and those were regarding the diagnosis of HHT and also regarding brain AVMs and pulmonary AVMs. So Dr. Chakinala went through this. I'm not going to spend a lot of time except saying that HHT, as you can see from this figure, kind of affects everything in the body. Every internal organ is affected, and the ones we kind of really worry about are the brain, the lungs, the liver, and the gastrointestinal tract, and obviously the nose, which causes nosebleeds, which is the most common manifestation of HHT. Everyone who is listening in probably knows that clinicians and care providers are not very familiar with HHT, and this typically leads to really underdiagnosis and long diagnostic delays before the right diagnosis is made. And epistaxis and GI bleeding are the most common symptoms, and obviously the 2 kind of bleeding complications that are most common in HHT. Dr. Chakinala mentioned the Curacao criteria. That's what we use in the clinic when we are faced with a question of whether we are dealing with an HHT patient or not. And I think genetic testing is extremely useful for confirming the presence of HHT in family members who may or may not show all the Curacao criteria to confirm it just based on clinical findings alone. So how did we come up with these guidelines? So this was a truly international group, so 15 countries. It was not just physicians, but it was genetic experts, people who really kind of understand how to formulate guidelines. So there were methodologists there, obviously staff from Cure HHT, and obviously patients, most importantly, who were part of the process. We used kind of very standard methodology. So this would be the kind of framework that would be used for making guidelines on any medical topic. So this is really state-of-the-art process that was used for this. And what happened was, even before the guideline group met in November of 2019, we had a kind of a pre-guideline work group, and we went through these 6 priority areas. Our group was assigned to GI bleeding. We went through all the literature in a very systematic fashion, and we kind of almost made some outlines of what we wanted to propose as guidelines when we kind of met in November. And so this was a very structured meeting, and only when 80% or more of the people at the meeting approved of something was that, that went past the initial approval phase. If there was less than 80% consensus, then either that guideline or that statement was dropped or reworded and then was again put up for a vote. So again, this required a 4/5 consensus. 4 out of every 5 people there had to agree for any of these recommendations to move forward. You've seen this picture before. Really quite an extraordinary group of people that met. Dr. Chakinala showed this picture again, and I really want to thank everyone. And I guess Dr. Chakinala and I are really speaking on the behalf of everyone in this picture who really gave all their expertise to the formulation of these guidelines. So just to kind of highlight what Dr. Chakinala said, HHT and GI bleeding are a very, very common problem. And you can see that the telangiectasias are located in the stomach, in the small bowel, and also in the colon. But like Murali said, if you see it in the colon, you're almost always going to see it further up, which is one of the basis of our recommendations for recommending upper endoscopies. And we rarely see people with GI bleeding who just have massive dumps of bright red blood or melena. It's typically more subtle. And as was mentioned earlier, I mean, sometimes it's really hard to know whether is this GI bleeding, is this just swallowed blood from nosebleeds? And so what I use as a guide is, if the degree of anemia is really out of proportion to how bad the nosebleeds are. So if someone is having mild or moderate nosebleeds, but then they're really anemic, then we almost know for certain that they're bleeding from their GI tract in addition to their nose. So if there's kind of a disproportionate anemia problem as compared to what we can kind of visibly see from the nose, that's what kind of clues us off to GI bleeding. Dr. Chakinala showed some of these images, and I just wanted to highlight them again. This is what your gastroenterology endoscopist would be looking for when they would do an endoscopy for you. These are the same spots essentially that are there on your lips, on the inside of your nose. So these are essentially, they look exactly the same. Here's a closer up image, and you can see this kind of just a cluster, a blood vessel that's kind of just clustered. And these are the ones that kind of ooze and bleed. And as you can imagine, just your small bowel alone, your small intestine is about 20 feet. So just think about how these can really start oozing and cause kind of this slow, continuous bleeding. So here's more of these kind of, and you can see some of them are really kind of faint and maybe kind of growing to become larger ones like this. So you can see kind of in this one image, kind of 4 different almost sizes and shapes of these AVMs or telangiectasias. And really, this is what the problem is. Just in this one small screenshot, you can see 4. So you can kind of imagine how many more there potentially may be in the rest of the intestinal tract. Here's a colonoscopy, again showing some fresh bleeding and also some kind of telangiectasias at the base of this picture. So we all know that all of these telangiectasias can cause pretty significant kind of slow drip anemia. And in about half the patients, we find anemia, and about 25%, this is pretty severe. We know that it causes a significant impact on quality of life. And we know, I'm going to show you some data on this, but we know that bleeding-related complications are the most common cause of hospitalization amongst HHT patients. So this is really something that we have to take very seriously. We know that endoscopic findings, so let's say, someone comes back to you and say, hey, we found 3 telangiectasias or 4 or 2. That has nothing to do with how bad or how good your anemia is. So the number of telangiectasias found on an endoscopy has really no bearing to how bad the true situation of the GI bleed is. And that's because just because you find 2 doesn't mean there's not more down the road. And as Dr. Chakinala mentioned, the SMAD4 mutation is a very specific subset of HHT that has its own screening program. And because of this increased risk of polyps and colon cancer, we really start super early in these patients, starting at age 15. And I'll talk a little more about the recommendation for that as we go along. This is that picture, that data I wanted to talk to you about. So let me walk you through this slide. This top figure is the number of patients hospitalized with a diagnosis of anemia. And as you can see from the year 2000 to 2012, you can see that the most common diagnosis of hospitalized HHT patients was anemia. The yellow one is congestive heart failure. The dark blue at the top is nosebleeds, and the red here is GI bleeding. So just between GI bleeding, epistaxis, and anemia, you can see that the vast majority of patients carry one of these diagnoses. Now, the question asked about age and severity of bleeding. So this is, again, a busy slide, but let me walk you through this. Here's the key to the figure. So the kind of the maroon colored is people who are age 70 or more. Kind of the bluish is age 60 to 69, and the yellow is age 50 to 59. So if you just focus on the top 3, you can see that for folks with anemia, ages 50 to 59, 60 to 69, and 70 or more, just look at this. This is about 80+% of patients. So 80+% of patients with anemia are older than 50, and almost 30% or 40% of them are actually older than 70. Same with GI bleeding. Look at that. About 40% are more than 70. Another 20% or so are between the age of 60 and 69, and another 20%-ish. So this is really a problem kind of 50 and higher, and it just kind of exponentially goes after that. And similar to the case for the rest of these complications, including epistaxis, CHF, etc. So we came up with 6 recommendations, and we covered topics including what type of endoscopic method to use for screening, what other tests we could possibly use, how do we grade severity of bleeding, and finally a couple of treatment options for how do we deal with GI bleeding. So I'll walk you through each of these recommendations now. So the first recommendation, and all of the recommendations, I have 2 slides for each of these 6 recommendations, and they'll all go through the same pattern. I'm going to first share with you the exact wording of what we put in the recommendation, and I'll then talk you through it. So the expert panel recommends EGD, which is esophagogastroduodenoscopy, as a first-line diagnostic test for suspected GI bleeding. And we specifically added that patients who meet colon cancer screening criteria and patients with SMAD4 HHT, the one we just spoke about, should also undergo colonoscopy. So if you are aged more than 50, or if you have some reason to undergo colonoscopy younger than that, or if you're a SMAD4 HHT patient, then your colonoscopy should be guided by those criteria. But the rest of HHT patients are well served with just an upper endoscopy. And this again is the 2 points which will come up in each of these 6 recommendations. The first point is the quality of evidence. don't be dissuaded or don't be disappointed, because you're going to see the word low for the quality of evidence in each of these 6. That doesn't mean that the recommendation is not valid or something. That just means that we don't have randomized, double-blinded studies and what we consider to be high quality, which kind of takes away all the biases. We don't have those studies for these recommendations, and it's almost impossible or unlikely that we're ever going to get studies, because some of these are just impractical to do. So the quality of evidence for this was low, but the strength of the recommendation was very strong. And you can see that there was a 94% agreement amongst everyone there that this is what should be the first-line treatment, or I'm sorry, first-line diagnostic test for HHT patients. So in terms of what we should think about, so what are kind of the my comments on this? I always recommend that the EGD be done in a center where folks know what they're looking for. It's very easy to do an EGD when folks are not really understanding the nuance of, looking for these small telangiectasias, and they just kind of glide past them. So really you want to do it at a center which is known to deal with HHT patients, and even an operator or an endoscopist who has dealt with HHT patients before. There are some practical considerations, right? If you have a nosebleed during the procedure, is that center capable of dealing with that? Do they have ENT backup? Things like that. Finally, people with AVMs in their lungs, you all have been told a million times that you need to have filters put on IV lines, etc. So those are kind of the precautions that we need to take. And again, we're going to talk about this on the 4th recommendation, but really we are kind of emphasizing that we want to avoid just repeated endoscopies and repeated kind of these cauterization procedures. And I'll talk more about that as we go along. And as again, wanting to really emphasize that for SMAD4 patients, the colonoscopy recommendation starts very early at age 15. If no polyps are found, then the colonoscopy should be repeated every 3 years. But if polyps are found, they should be repeated every year after the age of 15. And other patients who don't have SMAD4, who don't have the SMAD4 mutation, they can undergo colonoscopy as per what is considered to be routine screening practice. We move on to recommendation number 2. Again, the expert panel recommends considering capsule endoscopy for suspected HHT-related bleeding when the EGD does not reveal significant HHT-related telangiectasia. So basically, this is a recommendation saying, if you suspect GI bleeding and you don't find something on the EGD, consider a capsule. Why a capsule? Because the capsule goes through the entire length of the small intestine and large intestine and really can pick up things that is very difficult to otherwise get to. You can't get to 20 feet of small bowel unless you do something like a very invasive procedure like a double balloon enteroscopy, etc. So a capsule endoscopy can be a much simpler test to give you that answer. Again, quality of evidence, like I said, is always going to be low for some of these because we don't have randomized comparisons, but the agreement was very high. We have some small studies saying that in HHT patients, the yield of capsule endoscopy is pretty high and the safety is really quite good. And as you can see that everyone agreed that this would be a strong recommendation with about an 88% agreement. What are the kind of considerations? Again, we want to do this in conjunction with EGD. We don't want to kind of skip the upper endoscopy step and just move to capsule because it's just something that does not make that much clinical sense. And EGD is a very simple test. In fact, to place a capsule, you have to undergo an endoscopy anyways. And really, we want to kind of be aware that technology progresses quickly. So we're going to keep an eye out on this. Maybe a time comes where you just swallow a small pill like a large capsule or something and it just goes in and you don't need an endoscopy and you can just pop this at home. When that happens, maybe we'll look at this again and think about whether this should become like a capsule, like a test should become standard right up front rather than an endoscopy. So that was recommendation number 2. Recommendation number 3. Now this was really where we wanted to spend some time. And we as a group had to really kind of work this through and try to understand how can we grade GI bleeding severity, because you can't really see GI bleeding like nosebleeds. You can't say, okay, I bled for 20 minutes from my nose yesterday and today it was 30 minutes. You can't say that for GI. So how can we kind of assign severity? So what we did is we came up with this format. Mild GI bleeding was categorized as patients who met their hemoglobin goals with just oral iron replacement. So you're taking an oral iron pill and your anemia is under control, your hemoglobin is fine. And if that's the situation, you would be assigned a category of mild GI bleeding. Moderate GI bleeding are those patients who need IV iron to meet their hemoglobin goals. So just oral iron alone doesn't satisfy the degree of leak from their gut, and they really need IV iron. And severe are those patients who, despite needing IV iron or despite getting adequate iron, either oral, IV, or both, can't maintain their hemoglobin or have required blood transfusions to keep their hemoglobin up. So really, this is very kind of common sense, and everyone can kind of wrap their heads around this. But this is really the first time that we as a community have kind of graded this so that we can work off this framework to kind of help patients decide management and treatment options, etc. Again, as mentioned earlier, the quality of evidence was low, but you can see that there was a 96% agreement with this recommendation, and there was also a very strong strength of recommendations. Everyone really agreed that we need some kind of consensus on how to grade severity. So what are our clinical considerations? So as mentioned earlier, this is very wordy, but the bottom line is you can't use the number of lesions and the number of telangiectasias noted on endoscopy to decide anything. Really, what you're basing it on is what is the amount of blood being lost, what is the impact of that on hemoglobin, and what is it taking to keep the hemoglobin in normal range? Is it taking oral iron? Is it taking IV iron? Or is it taking blood transfusions? So we really want to focus on hemoglobin goals, which is very specific because we don't want to use one standard. Okay, let's keep everyone about 13 or 14 or 15, because depending on age, depending on sex, the range can kind of vary. And also we have to be mindful of what is practically achievable in some patients without interfering with their life. If I say I want to keep your hemoglobin at 16, but that'll require you to come into the infusion center every week to get an IV iron infusion, you might say, listen, I'm fine with it being 12 because I can live my life. But I don't want to be tied to an infusion center. I don't want to keep getting IV iron. So again, we want to make sure that we assign a hemoglobin goal that works for the patient rather than a specific number. This does not in any way say anything about the acute situation. So if you're acutely dropping your hemoglobin or something, this is just something that offers a guideline when things are stable, not in the acute situation. And we really want to use this after we have had a chance to understand how an individual patient is behaving. So the first time I see someone, I'm probably not going to assign them to one category because I really want to spend some time understanding what is the cause of their iron. Is their bone marrow working okay? Are they also bleeding from the nose? Have we done anything for the GI bleeding? Are there any other sources? Like Dr. Chakinala said, could there be cancer hiding somewhere? So we've spent some time understanding all that. We've spent some time giving iron through oral or IV routes, whatever. So we've spent a few months, and after that, we kind of decide whether this fits into the mild, moderate, or severe category. And finally, IV iron is kind of a mixed bag. Some folks might need one IV iron infusion once every year or every other year, and otherwise they're just fine with oral iron pills. They necessarily would not fit into the moderate category or severe category. They may be more in the mild category. So when we say IV iron, we really mean you need kind of regular top-ups with IV iron. Otherwise, your hemoglobin starts slipping. So those are kind of the editorial comments on that. And really what you want to think about is, it's like your GI tract is like a leaking bucket. And what we're doing with the hose is we're putting in either iron or blood. And really what we're trying to understand with this recommendation is, how bad is the leak? How much blood are you losing? Do we have to run the hose wide open, which means we have to give you IV iron or blood transfusions? Or can we just give you very slow trickle of iron through an oral route. So that's really kind of the question, if this analogy kind of helps you understand this recommendation. Coming to recommendation number 4, the expert panel recommends that endoscopic organ plasma coagulation, commonly known as APC, be used only sparingly during endoscopy. And this was quite a change. And this was one of the poll questions that we answered. And again, the quality of evidence was low. And really, we put this out there because we wanted to kind of focus attention away from this idea that you can really burn your way through a bad GI bleeding problem, and instead shift attention to therapies that can actually change the whole nature of the telangiectasias in the GI tract. And again, the strength of recommendation here was weak because there was debate either ways whether we have enough evidence to even make this recommendation, but our group felt pretty strongly that we wanted to send a message that you can't really burn your way through a bad GI problem. So what are my editorial comments? So again, we understand that if you see one telangiectasia, there's going to be multiple. And if you keep burning these, you end up causing injury to the lining of the GI tract. And there's some kind of studies that say the more you kind of do APC type therapies, the therapy itself might promote further kind of AVM or telangiectasia formation. So we really want to be very judicious in our use. And we really want to avoid this kind of repeated injury. And we want to kind of understand that this is something that should be reserved to centers where that are really quite experienced with doing this. And APC and can be used even with a double balloon enteroscopy, which is this kind of procedure done in an operating room under general anesthesia, where the endoscope is kind of advanced all the way through the small bowel. So in severe bleeding cases, sometimes just to get things under control, we suggest that this be used by experienced operators. Here's what APC looks like. Again, this is the probe at the bottom of the screen, and the probe really doesn't come in contact with the tissue. It's actually a non-contactless, it's a contactless method where an arc of plasma of argon kind of just goes and just burns the superficial layer of the tissue. And as you can see, it really burns it. So, and that's the worry, is if you keep doing this, does the actual process of doing APC actually cause more long-term damage? And I think of it, I explain it to patients like this is whack-a-mole. If you whack out 6 of these, 6 more are going to pop up a few months later. So you can't keep doing this over and over again without doing something to fundamentally change the numbers of these new lesions coming up and to decrease the growth and also decrease the fragility. And that's where things like Avastin and other anti-angiogenic treatments come in. So now we move on to the last 2 recommendations, which is recommendation 4 and 5, and these are, 5 and 6, which are related to treatment. So for mild GI bleeding, we recommend treatment with oral antifibrinolytics, which is basically oral tranexamic acid. And you can see that the quality of evidence was low, but there was very good agreement. Strength of recommendation was weak because there was just limited evidence to back this up, but we thought that this was a low-risk intervention that could potentially provide benefit. So we recommended that we can start at something like 500 milligrams twice a day. In the US, I think it's a 650 milligram pill, so that can be started at 1 or 2 pills a day and kind of gradually worked up to 1,500 milligrams 3 times a day, or in case of the 650 milligram pill, it would be 1,300 milligrams 3 times a day. And you can see that there are some safety comments. If you can co-administer it with things like Avastin with the care, but if you've recently had a blood clot in your legs or in any of the arteries and stuff, we recommend that this not be used. And relative contraindications are atrial fibrillation, which can again increase the risk of thrombosis. And if you have any other kind of thrombotic tendencies, either inherited or acquired. The last recommendation is that for moderate to severe patients, we use things that can actually change the nature of the telangiectasias, can prevent new telangiectasias from coming, can maybe stabilize the existing ones, and maybe even shrink the existing ones. And I'll show you some pictures to suggest that this might be the case. So we suggest that for moderate to severe HHT patients, we use intravenous Avastin, or Avastin is the brand name, but the chemical name is Bevacizumab, or other systemic anti-angiogenic therapy. There are some that are that are being used, including pomalidomide, its older cousin thalidomide, and recently pazopanib or Votrient. So there's an IV version of there's IV version, which is Bevacizumab, and then there's 2 or 3 oral alternatives. Again, this was a moderate quality evidence, again, because the data on this is just getting stronger and stronger and stronger every year. So I think at some point this might even become a strong quality of evidence, or a high quality of evidence. And you can see that was really excellent agreement amongst everyone that this would be a valid and a good recommendation. Just a couple of points. IV Bevacizumab, it's the typical kind of dose is 5 milligrams per kilogram every 2 weeks for 6 doses. And then after that, patients are kind of treated differently at different centers. But the typical thing is we have to do something after that. Some folks like to give Avastin every month on an indefinite basis. I like to maybe give 3 or 4 more doses a month apart, and then just wait and watch and see what happens, and then give more doses if the bleeding kind of recurs, almost like a wait and watch type approach, and just top up with Avastin if the bleeding recurs. So that's different approaches. And like I said, these things fundamentally change the nature of the telangiectasias rather than just burning them with APC. So here's a patient on the left of the screen, classic. You can these are things you might see on yourself or your family members. And look at that, after 3 doses of treatment with IV Bevacizumab, you can see that these telangiectasias have really disappeared. And we believe that the same thing happens in the nose and the same thing happens in the intestinal tract. It's just harder to do repeated endoscopies to prove that. Similarly, same patient, you can see that the tongue at the start had all of these telangiectasias, and the same patient's tongue after 6 weeks of Bevacizumab treatment, and you can see a remarkable change. So this is really a transformative therapy, I believe, for many patients. How well does Bevacizumab work? Incredibly well. So this was a very large study, which a bunch of centers came together, including ours. Dr. Al-Samkari from Massachusetts General was the lead author on this paper. And you can see that to the left, the figure on the left is blood transfusions, figure on the right is iron infusions. And you can see that in the 6 months pre-treatment, that is what the pre-TX means, you can see the number of blood transfusions, and you can see that the first 6 months after treatment and the second 6 months after treatment, you can see a significant drop-off in both blood transfusion needs and iron infusion needs with patients receiving IV Bevacizumab. What happens if you bleed really bad? So we divided patients who needed a whole bunch of blood transfusions prior to starting Bevacizumab. In this case, more than 17. This was the group that received 10 to 16 blood transfusions, 5 to 9, and 1 to 4. And you can see that in each of these cases, the reduction in either blood transfusion or iron infusion need was equally dramatic. So even if you're bleeding really, really bad and needing a whole bunch of blood transfusions or iron infusions, starting something like Bevacizumab can make a dramatic difference in your quality of life. Just to wind up, Cure HHT has come up with this really excellent checklist. I think it's something that you folks should check out. It can maybe guide your interactions with folks like us to keep us honest about addressing all your concerns and making sure all your questions and your screening and everything is going as per our own recommendations. So key takeaways, I think, this is a tremendous opportunity to kind of leapfrog off these guidelines, use them to kind of take care of your health and really improve the quality of life. Please share this with everyone. Tell them that it's there, and the more people are made aware of it, the easier it becomes to get things approved through insurance and just making people aware that these recommendations exist. I really want to finish up by thanking the McMahon family. I had a chance to meet with them in Toronto, and really a fantastic group of individuals without whose support, I don't think we would be having this this webinar right now. So really a heartfelt thanks to them. And that completes my talk. Thank you for listening.
Great, Dr. Iyer, thank you very much. And I want people to know that we will go past the 8 o'clock hour so that we can get to your questions. But before we do that, I'm going to launch our last poll while our patient, Ivadine Herder, activates her screen and audio. And so the last question is just asking, what is the most common source of GI bleeding? And does a systemic anti-angiogenic therapy like IV bevacizumab, has it shown to reduce bleeding and improve anemia in patients with moderate to severe bleeding?
And I think folks have gotten it right in both cases. The stomach and the small intestines are definitely the most common source of bleeding in patients with HHT. And you're absolutely right. I'm glad no one has any doubts about the benefits of bevacizumab and other anti-angiogenic agents for the management of HHT-related bleeding. And I really want to thank Ivadine for being here. And Ivadine, please go ahead.
Well, I am very thankful to be part of the program today and have the invitation to share my experiences. My son, Jason, was diagnosed with HHT in 2007 after suffering a brain abscess and had surgery, and we found out that this was in our family. And I didn't do very much about it that right away, but in November of that year, I did go up to Mayo to have HHT testing because we really didn't know where this came from in our family. They really didn't find a lot of information for me. They didn't find any evidence of any AVMs. And then in September of 2015, I had my first blood transfusion. And then in December of 16, I was hospitalized for 3 days. That's where I started feeling very weak. I thought maybe there was something wrong with my heart, and my husband took me to the emergency room, and they diagnosed me with low blood count. It was down to 6.4, my hemoglobin was. And they did some testing and so forth. And a few days later, a couple weeks later, I had a capsule EGD, which didn't show any signs, but they had cauterized some spots in December. And finally, Jason said that Dr. Iyer wanted to see me because that's his doctor up at Mayo. And I went up and made an appointment in February of 2019. And he recommended that I get on Avastin. And Avastin did a very good job for me for almost a whole year. And then in 2020, I ended up in the hospital again for 8 days at Allen and 4 at Mayo, and many tests and many scopes and cauterizations and so forth. And we did a consultation with Dr. Iyer at that point too. And I started May of 2020, then several months later, I started on Tranexamic Acid, or if that's the correct pronunciation, I'm not sure. And my hemoglobin started to climb and it stayed stabilized. And then in October of last year, I had another blood transfusion, and in December I was hospitalized, or January I was hospitalized again with bleeding and low hemo. And so Dr. Iyer suggested that possibly I go on Votrient, which is a new medication. And my hemoglobin has continually climbed. It's up in the 13s now. It's been a long time since I've been at that level. I started on 1 pill a day, and after 4 or 5 weeks, I was able to drop down to just 4 pills a week instead of 7. And so far, I have had no side effects of the medication, and it has worked very well. But being a patient who has intestinal bleeding, it has really hit me in my older age. Before this, I had no symptoms. I had a few nosebleeds once in a while, but nothing really major. And I'm very thankful also that Dr. Iyer has been able to consult with my doctor. I had breast cancer in 2011, so I was established a patient at a cancer center here at Unity Point in Waterloo, Iowa. And the doctor there is very easy to consult with Dr. Iyer, and they keep in touch with each other on my case. So I feel like Dr. Iyer is my primary care and my secondary care is the cancer center. And I've been very fortunate to have that because it's not that far away. When I first started Avastin, I took my first treatments up at Mayo over a 2-month period. And then that was all transferred down here to the cancer center in Waterloo. And it was much more convenient for me to come to here. So I don't know if there's any further information you need, but I am very thankful for the expertise of the HHT Center at Mayo and for Dr. Iyer. And I really appreciate all the work that we've been able to accomplish. And I feel a lot better that I'm in very good hands.
Thank you so much, Ivadine. I mean, that is just a phenomenal story, and you've literally touched on every point that they've covered this evening. So I think that people will really appreciate hearing from you about that. And I just want to share that if you have any questions outside of tonight, you need a referral to an HHT center, you know, feel free to contact Cure HHT. We are available by phone, by email, and also on our website. There's a wealth of information. I've put a ton of links in the chat that you can access. But also there is a contact us form there if you want to submit a question that way. And so I just really want to thank Dr. Chakanala and Dr. Iyer for an incredibly thorough overview of, you know, GI bleeding and the management of that and all of the guideline recommendations. And for Ivadine, who we're just very grateful for your willingness to share your story with us tonight. So as we would have expected, we do have a lot of questions, so we will get started. This would be for one of our doctors, just asking of, does the process of taking a lot of IV iron, does that have an impact on the liver? And is there kind of a limitation to doing that?
I can take that. I don't think that taking extra iron would impact the liver as long as we are monitoring things like IV, like iron levels, ferritin levels, etc. I understand where your concern is coming from. We talk about iron toxicity to the liver for people who take like supplements that are not necessary. But remember that kind of that cartoon I showed with that bucket kind of leaking. So in fact, if you're leaking from your intestinal tract with GI bleeding, what we're essentially doing is we're just replacing what's otherwise being lost. And so the iron that we're giving IV or oral is really not going to the liver for any specific reason, or it's not accumulating there because you're barely kind of keeping up with what you're losing. So it's really not going to cause liver fibrosis or toxicity. I hope it answers, yeah.
I can add to that I've been on iron pills for many years, and now I'm also taking iron infusions for the past several years, and I have had no problem with my liver counts either.
Yeah.
I think the concern or confusion some people get is that there are other types of anemias, like classically sickle cell anemia, where patients are anemic all the time, but that's because their red blood cells are being destroyed in their body, and the iron that's in the red blood cells basically gets recirculated and it's still inside the body. Well, in HHT, you're anemic because you're bleeding out. So whenever you bleed out, you're bleeding out the iron too. So you're actually losing the iron out of your body, as opposed to like sickle cell disease, where the iron just stays inside and gets trapped in the liver, and then that eventually causes toxicity to the liver. So there's a big difference there. And as long as you know, we don't go overboard and you know, we track your hemoglobins and iron levels, it shouldn't happen. And I've been doing this for about 15 years, never had an HHT patient develop iron overload.
Great. Well, thank you very much. So we have actually a couple of questions where people are just asking, is there any kind of diet that can either help with GI bleeding or that might instigate more GI bleeding?
Morale, you want to take that?
I can start at least. I mean, in terms
Yeah.
of instigating GI bleeding, I'm not really aware of anything from a diet standpoint. There are certain supplements or, alternative medicines, classically ginseng, for instance, which has some effect on platelets and can make you bleed more. So you have to be careful about some supplements that if they have any platelet tendencies or there's a warning that you might bleed more, then you need to avoid that. But beyond that, I don't think there's anything that's harmful that I can think of, at least. Now, the flip side is, can you do something in your diet to help the situation? Probably not so much from the bleeding standpoint, but there are things in your diet that can help with increasing iron. There are certain food items that are particularly rich in heme-based iron, which is what you need to really absorb and build up your iron stores. Some of the classic things, now it's not for everybody, but for instance, liver and steak and even chicken and salmon. You can search this online or WebMD, and you can find lists of food that are really high in iron. Now, just don't go crazy and have such a restrictive diet that you're focused on that and start eating unhealthy in other ways. But mixing in some iron-rich foods, especially if you like them, is a good way to try to boost the amount of iron in your diet and therefore help compensate for the bleeding that's taking place.
I completely agree. I think, and also different patients have different experiences with different foods. So a food that works, let's say in reducing nosebleeds and let's say by extension GI bleeds in one patient might not work the same way for others. So it's kind of a mixed bag. And really, if you also have nosebleeds in addition to a GI bleeding, maybe anything that decreases your nosebleeds, by logical extension, might also decrease intestinal bleeding. But like Dr. Chakinala said, we really don't have a good recommendation or understanding. Yeah.
So we've obviously had a couple questions relating to different drug therapies, and Ividine touched on pretty much all of them. So, the question is, is the path that she went on in her, drug therapy, is that the standard evolution, or is it really dependent on the individual? And what is the difference between, for instance, tranexamic acid and bevacizumab?
Sure, I can take that, Murali, if you. So really, the focus of our recommendations really was to highlight that we want to kind of move away from this kind of previous way of doing things, which was just to do endoscopy after endoscopy, and move to something that can fix these telangiectasias, either reduce their size or make them more stable or prevent new ones from coming up. Tranexamic acid works for the milder end of the spectrum, because what it's essentially doing is it's kind of helping to stabilize clots that have already formed on some of these telangiectasias that are bleeding. So it doesn't really, we don't think it changes the nature of the telangiectasias, but it just maybe stabilizes a clot that's already formed on them and prevents it from breaking off. On the other hand, things like bevacizumab or pazopanib or pomalidomide, these medications actually are what we call anti-angiogenic agents. So what they're actually doing is, angiogenic just means they're related to blood vessel formation, and anti-angiogenic means they prevent the growth and formation of new blood vessels. So we really think that they shrink existing telangiectasias and maybe stabilize them and maybe prevent new ones from forming. So like the picture I showed you of those lips, we really see a shrinkage in that. And I have so many other patients, I'm sure Dr. Chakinal also has, who take these medications and they can see kind of a visible change in their face, in their lips, in their tongue. And they say, oh, this spot was really bothering me and it's really shrunk in size. So the bevacizumab and pazopanib and pomalidomide, those are medications that we use if your bleeding is severe enough, where we think that putting you on these medications long-term is really significantly going to improve your hemoglobin, and it's worth the risk of being on those medications. So it's really kind of a graded approach. We want to essentially go away from just doing endoscopy after endoscopy, which typically buys you maybe a few months or a few weeks of better hemoglobins, and kind of move from that to using something that can fundamentally change the trajectory of the HHT telangiectasias. Regarding which therapy to use, I think I would discuss this with your treating physician, and whatever they're comfortable with would be the way to go. But it really sometimes is just dependent on what agents your physician or healthcare provider is comfortable using, and that can sometimes vary from center to center a little.
I might add to that I was kind of skeptical about going on the Votrient, and Dr. Iyer assured me it was 1/8 the dose that a normal cancer patient gets. And so I went on it, and I was very conscious of any side effects, and I have had none, and I'm very pleased with that. But I was really pleased when he told me that I could drop the dosage down to 4 pills a week instead of 7.
Yeah.
And it's been very effective because I haven't had this high hemoglobin counts for a long time.
The last point I just wanted to mention, I'm sure people have this, is don't look at the online side effects of any of these medications, because if you read them, you're never going to come close to a medical center, right? So stay away from the side effect profile, because the reason is because most of the side effects are when you use it at the high dose used for cancer patients, or you use it along with chemotherapy. And what we found with, for example, Bevacizumab, the same kind of inhibit bleed study that I showed you a couple of figures, that same paper showed that this is a very safe medication. And that paper had over 230 HHT patients who had received Bevacizumab. So again, the labeling is somewhat misleading for HHT patients, because A, you're not receiving chemotherapy, and B, if you're using something like pazopanib, you're using a much, much lower dose as compared to what a kidney cancer patient, for example, would be receiving. So just a disclaimer.
I would just, add the point, more of a general point, and it's great that we are developing more options for nosebleeds and for GI bleeding where we didn't in the past. And this is one of the reasons why I think going to centers for guidance is really important. Because I think we can sort of look at the multiple options and help pick out what might be best. And then, the other point I want to make, and Vivek touched on this during his talk, we don't have a lot of high-level evidence for a lot of these therapies. And we absolutely have hardly any what we call head-to-head trials. I mean, we have a little bit of nosebleeds, like the nose study, but like in GI bleeding, we've never compared one therapy versus another. And when physicians don't have that kind of comparative effectiveness data, we have to look at things like cost, toxicity, the frequency of a dose, how convenient or inconvenient. There's a whole lot of things that I think we think about in terms of coming up with a treatment recommendation. But in general, I think physicians want our patients to be on the least toxic, most affordable, most tolerable, or best tolerable treatment. And so if you keep those principles in mind, we generally take that tiered or multi-step process. Well, in GI bleeding, I think the first thing is making sure your iron levels are adequate. And we haven't really touched on adequate iron replacement. And for many GI bleeds or patients with GI bleedings, simply just getting a good iron schedule, like an infusion every 3 months or a daily iron pill, will take care of the problem, because you're dealing with the main symptoms of GI bleeding, which is anemia. So you might still be losing blood, but that's okay if your hemoglobin is still 12 and you feel good. So that's cheap. Iron's easy, it's cheap, well tolerated. We already said it's not toxic. And then if that's not enough, then we think of one of these other therapies, like maybe tranexamic acid. Hormonal therapy was tried for many years and had some efficacy as well too. And then, the anti-angiogenic therapy is kind of the next wave here. Now, are there some patients on first meeting, we just feel like, no, you need to go on anti-angiogenic therapy right off the bat? Yeah, there is that rare patient. But I think for most patients, we would want to come up with the least toxic, least, expensive, and most convenient therapy, and see if that will adequately get us to our goals for treatment.
Okay, great. Well, thank you. And sort of leading off of that, I guess I would say, Dr. Chakanala, can you just kind of address the fact that not everybody has access to an HHT center? I mean, at Cure HHT, we really encourage anybody who contacts us to, make the pilgrimage to visit an HHT center at least once. And, it's our belief that most of the centers will then coordinate with local physicians for patients. And so I just was wondering if you could talk a little bit more about that, because obviously Dr. Iyer has done that for Avidine and your experience at WashU.
Yeah, I think quite a few things we can say about that. I mean, first off, hats off to the foundation for really promoting the growth of the network of centers out there. When I started doing this in 2006, there were 8 centers, I think 9 in North America, 8 in the United States. Now, I've lost track of how many there are, but there are many more centers out there. We're in the close to 30 now, aren't we, Nicole, in North America?
Yes.
So there are many more centers out there. I think Nicole described a very nice paradigm that, people feel like, well, I can't go to a center because I can't keep going so far away. Well, even if you can't keep going, it's good to go and get that initial consultation where we view that as a way for us to outline the issues, give you a list of recommendations that you can take back to your local doctors, and we can continue maybe working with your local doctors on how to longitudinally manage the situation. And then the next thing I would also mention is that this is actually something we can thank COVID for. COVID has pushed the needle for telehealth and telemedicine. And, while we still have some legal issues and potential issues of reimbursement, many patients now can take advantage of telehealth. And I personally have done quite a few initial HHT consultations strictly over Zoom with patients in Illinois or Missouri where I practice, and they found it very useful. Even if we can't lay hands on the patient, we can hear their story, look over their lab work. We can even do a mini physical exam over Zoom, to be honest. So telehealth hopefully will stay with us, and that's another way to potentially reach out to a center and get expert care without making the long trek across the state or across multiple states.
And to that point, can I just ask, one of the questions is really relating to how does a person encourage their local physician to utilize these guidelines and, to possibly refer their patients to a center for that one-time visit?
I think, one is use some of the tools, the printouts, the flyers, and the pamphlets that the foundation has, like the GI bleed checklist. Take it to your doctor because they probably haven't heard about this or looked at this yet. And I think, having a collaborative conversation with your physician, I think you'll find that most doctors, when we're talking about rare diseases like HHT, they're very supportive and understanding when patients provide them information and resources and websites that might help them manage your case. It would be different if there's a common disease with lots of evidence and lots of great understanding, and you may challenge what's the dogma. That's not the case here. There isn't dogma, but there are some expert recommendations, a consensus recommendation for a rare disease. And I think healthcare professionals are very accepting in those situations of patients who have done their homework, bringing in information that they can potentially utilize for the care of you and their other patients.
I really want to echo everything that Dr. Chakanala said. I just wanted to add that the other benefit of reaching out and kind of interfacing with an HHT center is you're up to date on what's available, because we as center directors meet many times a year, virtually have discussions about, okay, what are the research projects out there? What can we do? What are the updates in the literature? So we are trying our best to kind of keep on top of everything that's kind of coming out of the HHT research world. So interfacing with an HHT center kind of gives you that advantage of oh, is there a clinical trial that's available to you? For example, right now we have a pomalidomide trial for HHT-related bleeding. You wouldn't know that if you never interface with an HHT center or visit the Cure HHT website. So again, I think just having that kind of regular scheduled interactions can kind of give you that update on what is out there that can benefit you and your family. And I really felt that a lot of the physicians out there really want to take our advice and really implement it and really look up to us for guidance. And some become very comfortable managing HHT. And I really, really like that. But regardless, I think just once in a while, just coming back and touching base with your nearest HHT center would make a lot of sense.
I will have to add to that my local doctor was very impressed with the effects of the latest drug that I was on and its effect on my bleeding and my hemoglobin. He was quite astounded. So I think what patients need to do is be sure you ask your doctor plenty of questions and don't be afraid to ask for referrals.
Great. Well, I appreciate all of your feedback. And, you know, I really do want to let the HHT community at large know that we do have currently, we'll be announcing a brand new HHT center in Arizona. That announcement will come in the next couple of weeks. We also have applications where centers, universities are being in the process right now of becoming HHT centers, and that's in Alabama, Florida, and another in southern Texas. So, you know, we are constantly trying to also increase those numbers. And again, if you know, live in an area, even if there isn't an HHT center, give us a call at the foundation and we'll be happy to put you in touch with the closest center or let you know if there's a group in your area that's looking to become a center and working through that training process. Because it is a training, it does take a good number of months, if not a year, because we want to make sure that they're very knowledgeable teams of doctors at the centers. And every new center is connected to a more established center as a mentor center for that kind of assistance going forward. So we've obviously gone over quite a bit tonight, and I really appreciate our speakers. I appreciate our audience like hanging out there and going through all this. This was incredibly valuable information. I've been with the organization for 14 years, and I have to say I learned more than I can count on two hands. So I'm incredibly grateful. And on behalf of everyone at Cure HHT, again, I just want to thank you for being here tonight and connecting with us, because we are the only patient advocacy organization funding research, providing education materials, and advocating for this disease, as well as expanding treatment centers around the world. And we just want you to know that we are here for you and that we are truly grateful for today's speakers and for the McMahon family's commitment, as they quoted, to pay it forward so that future generations have more effective treatments and ultimately a cure for HHT. And without their financial support, the Guidelines Conference would not have been possible. We also want you to remember that we have this complimentary copy of the Comprehensive Guide to Managing Your HHT. It actually includes all of the fact sheets by topic and the checklists. So, you know, if you haven't gotten your copy in the mail already, you can click on the link in the chat, or you can go onto our website to the Join Us form and choose it there. And lastly, I want to mention that this is just one topic in the International HHT Guidelines Education Series, and we will be covering every topic separately. So you can register for each free webinar on our website at curehht.org. So I just want to thank again Dr. Chakanala, Dr. Iyer, and Ivadine Herder for volunteering their time tonight. This program has been recorded and will be posted on our website, and we truly appreciate your participation. I again wish you all a happy St. Paddy's Day and hope you enjoy the rest of your evening. Good night.
Nicole, I just wanted to add that everyone should get the COVID vaccine.
Absolutely.
Just plugging
and
that.
We have a webinar on that's recorded
right,
and on our website that gives a lot of great information about the COVID, the vaccine, how it relates to HHT.
Perfect.
So check that out and definitely get vaccinated. All right. Take care, everybody. Good night.
Bye, everyone.
Good night. Thank you.
Bye-bye.